Thank you. Well, the title of our theme-based research scheme is shown on this slide. Unfortunately, Professor Maria Long is not in Hong Kong at the moment, so she cannot join us this morning. So for our presentation, I'm going to talk about the initial introduction of the clinical problem, and Dr. Josephine Koh, who is our Senior Research Assistant Professor at the Department of Clinical Oncology, is going to tell you about our scientific findings. So first, the problem. So we're moving a little bit north from the stomach, coming to the gullet as esophagus. Just like stomach cancer, esophageal cancer has the highest incidence in the world is in East Asia, and China has the highest incidence among all the countries. So we really have a big problem with esophageal cancer. And in some provinces in China, this is the #1 cause of cancer death in China. So I'm a surgeon, so when most of the esophageal cancer are looked after by us, so these are some of our challenges. Most patients, they present with a very advanced stage. So early cancers, they basically do not have any symptoms, so by the time patients have symptoms, they're usually pretty advanced. And compared to the rest of, say, the GI tract, the stomach, and the colon rectum, even for a very small early esophageal cancer, the incidence of lymph node metastases is substantial. These are elderly patients. They are often heavy smokers. They consume a lot of alcohol, so they have a lot of smoking and alcohol-related disease, making them hard to deal with. The surgery for esophagus is very complex. Often it involves operating in the chest, in the abdomen, and sometimes in the neck, so it's a great challenge for the patients. And even if we do a successful operation, the early relapse and high recurrence rates seem to be the norm. So there is a great need to develop novel treatment strategies to improve the outcome. Now, we have actually been investigating the various ways of treating this cancer way back in the 1990s and in the early 2000s, and this is a publication we had early in 2003. At that time, we were one of the first groups to investigate the use of a pre-operative chemotherapy and chemotherapy and radiotherapy before surgery in order to improve the long-term outcome. So as you could see that this is not a randomized trial, but just by introducing the type of multimodality therapy, we have improved the outcome of this cancer. But still, this is pretty suboptimal. Chemoradiation now has become the standard of care in the current era, but still, we are still looking at about 5-year survival, around only about 40%. I think the main reason is that whatever good surgery that we can do radiotherapy. Those are local treatment. And esophageal cancer tends to metastasize. I don't need to explain to you the biology, but then the esophageal cancer, just like a lot of cancers, are highly heterogeneous, and there is a very high propensity to metastasize. So obviously, we want to develop personalized medicine, just like the previous speakers have talked about. So we talk about chemotherapy and various drugs. Currently, the drugs that we are using for esophageal cancer is really pretty primitive. These chemotherapy, they are non-selective, and there are significant side effects. It would be nice if we can target specific alterations in the genes of these patients. It would be nice to have predictive biomarkers for therapeutic response so that we don't waste our time giving people chemotherapy and useless drugs. That would increase the treatment efficacy and also with fewer side effects. Esophageal cancers research has been lacking compared to some other cancers. For example, in colorectal cancers, we know that there are a lot of genetic mutations. There are already drugs that are developed specifically for these mutations for colorectal cancers. But for esophageal cancer in this field, this is really very lacking. So I think the key challenges for us clinicians looking after these patients are, well, first, as a surgeon, I want to improve the surgical results even better. When we talk about the surgical results of 30 years ago, you have about 1 in 10 chance of not actually leaving the hospital when you have this type of surgery. Now we are bringing it down to 1 to 2%. But despite the improvement in mortality, complications rates are still substantial. We have to integrate more with these so-called multimodality therapy, chemotherapy, radiotherapy, and in recent years, immunotherapy is the new kid on the block. We need to identify novel targets to develop precision drug regimens. We need to predict the response to treatment so that we're not wasting our time giving patients toxic drugs that are not going to work. And we need to monitor the treatment effects, and we talk a lot about liquid biopsies these days, and this is one of the directions that we need to do in order to monitor the patient's disease status instead of doing expensive imaging studies all the time. So this is a general introduction of our clinical problem. I'll leave it to Dr. Josephine Koh to talk to you more about the scientific findings from our research grant. Dr. Koh.
Thank you, Professor Law. So there are several key questions to investigate in our project. The first one, what are the key genes and molecular pathways contributing to tumor metastasis and tumor heterogeneity? Can we utilize liquid biopsies for real-time monitoring of patients at the different treatment stages of the disease? Can we establish cellular or animal platforms for drug testing and to understand the underlying biological mechanisms of tumorigenesis? Can we use of this new discovered information on novel targets for development of drug and precision medicine? So, whole exome sequencing analysis in the primary ESCC demonstrated that patients with increased lymph node metastatic with lymph node metastasis associated with increased chromosome instability. Further single-cell RNA sequencing and whole exome sequencing identify multiple dysregulated biological pathways relevant to this high chromosome instability, including the epithelial mesenchymal transition, which is a process enabling tumor cells to gain invasive potential, and also hypoxia to enable the cell to survive in the anaerobic conditions, angiogenesis to form blood vessels, RNA metabolisms, and detoxification. Then we perform whole genome sequencing analysis in the primary ESCC tissues and the synchronous metastatic lymph node tissues. We detected increased retrotransposon line insertion in the group of patients with lymph node in their lymph node metastatic lesions. Further data analysis suggested that the patients with lymph node metastasis can be classified into two groups based on their chromosome instability status. For the patient with lymph node metastatic with high chromosome instability, they are characterized with also increased with the increased retrotransposon insertion and increased number of structural variations. Then further characterization of ESCC nodal metastasis by spatial analysis, suggesting that those lymph node metastatic tissue with high line 1 expression have associated with high upregulation of the Ki67 and downregulation of this STING protein expression, suggesting increased proliferation and decreased anti-tumor innate immunity. Through the multi-omics analysis of the primary ESCC and the matched lymph node metastatic tissues, our findings suggested that the high chromosome instability is significantly associated with the lymph node metastasis in ESCC. ESCC patients with nodal metastasis can be further stratified based on their chromosome instability status for prognosis, and high NI1 expression can be used as a surrogate marker for high chromosome instability for clinical applications. In another project, we utilized the multiple whole exome sequencing strategy to examine intratumor heterogeneity within different regions of the same ESCC tumor. This heat map summarized the genetic mutation frequency of the putative ESCC driver genes across 12 patients. For each column represents the mutations detected in each region. For the homogeneous mutations detected in each region of the same tumor, they are in gray color. For the heterogeneous mutation not detected in every region of the same tumor, they are in red color. Here, we detected several patients with high degree of intratumor heterogeneity associated with poor prognosis. We also detected additionally 28 genes that are frequently mutated in these patients, suggesting the single biopsy strategy is inadequate to capture the tumor heterogeneity. Instead, the multi-regional assessment can better trace the tumor clonal evolution for personalized treatment. About 10% of the ESCC patients will develop dual primary cancers. And the most frequent sites of these dual cancers are located at the hypopharynx. This type of dual cancer patients with both ESCC and also hypopharyngeal carcinoma cancer are ideal for us to examine tumor heterogeneity. In order to understand whether the same driver mutations can drive two different types of cancer in the same patient, we obtain, again, multiple regions within the esophageal cancer and also the hypopharyngeal cancer and perform the whole exome sequencing analysis. As expected, we detected a high degree of intra-tumor heterogeneity in each of these tumors. Interestingly and unexpectedly, we detected a distinctive genetic alteration patterns between the individual lesions of this synchronous dual ESCC patient, suggesting our findings suggesting the concept of field cancerization, meaning that both the epithelium of the esophageal and the hypopharyngeal epithelium are exposed to the same carcinogen. In this case, it is the smoking and the alcohol, which make the field become unstable, and individual mutation in each region can be developed and resulting in different cancers. The footprints of mutagenic process can be reflected by mutational signature in WES analysis. Here, there are 30 different types of cosmic signatures. For example, the number one is associated with aging, which is believed to be important in most types of cancers. You can, for signature 16, it is associated with alcohol. You can see that this group of dual cancer patients has 100% of cosmic 16 signature compared to only 40% in our primary ESCC cohort. And this was validated in a larger ESCC-WES public data set. This dominating cosmic 16 mutational signature for patients with ESCC-related dual cancer suggests alcohol is an important etiologic factor. It is very important to understand the ESCC tumor ecosystems and their interaction of stromal cell with the epithelial cells. Therefore, we obtain the resected tumor tissues and the biopsies and utilize this single-cell RNA-seq transcriptome approach to understand their interactions. Here, our data can identify different stromal cell subtypes within the malignant epithelial cells. It is very highly heterogeneous. We identify over 40 different epithelial cell types. And we also identified a subset of 500 genes and classified them into 6 signatures. And one of the signatures was associated with poor prognosis, validated in the public esophageal cancer data set. In order to address the unmet clinical need of early predictive biomarker for treatment outcome mentioned by Professor Law, we obtained FFPE blocks from 17 pairs of good and poor responders to pre-surgery treatment and perform mutational analysis in screening a panel of 130 oncology genes. We identified TP53 is the most frequently mutated gene, and the missense likely pathogenic mutations was exclusively present in poor responder with marginal significance, and these findings need to be validated in a larger sample cohort. In addition to conventional specimens, our project also utilized liquid biopsies to address tumor heterogeneity and also to identify predictive and prognostic biomarkers. Circulating tumor cells was considered as cyst for metastasis, which kills 90% of the cancer patients, and the CTC circulating in the bloodstream originate from the primary tumor and the metastatic lesions. Because of its rarity, it is technically challenging to identify and isolate them. It's just like finding you among 7.4 billion people. So the key clinical applications of CTC and circulating tumor DNA as liquid biopsies include early diagnosis, prognostication, stratification for treatment outcome, and also tracking the minimal residual disease and real-time monitoring of the response, and also tracking the clonal tumor evolution. Here, our lab has already established the protocol for enriching the CTC by size. The larger CTC can be separated from the smaller blood cells when they're running through this spiral microfluidic chips, and then we perform CTC enumeration by immunostaining with epithelial markers. Based on the ESCC treatment options and the schedule, we collect the blood samples at various time points to identify the predictive and prognostic biomarker. As an example, in this group of patients treated by palliative chemotherapy, we collect blood samples at the baseline, at pre-cycle-free, end of treatment, and at the relapse. And then we perform CTC NGS imputational profiling. We found that the group of patients with increase of genetic alterations comparing the baseline versus the pre-cycle-free time point has shorter progression-free and overall survival compared to the group of patients with decreased genetic alterations. These cartoons show how CTC are circulating in the bloodstream in order to survive in this hostile circulatory environment. One of the strategies that the CTC used is to form the circulating tumor microemboli, meaning that they form clusters among themselves and also with the red blood cells and the platelet. This is a rare phenomenon. However, we detect a few patients carrying these CTC clusters at the time of pre-surgery associated with an earlier relapse. The risk stratification based on the longitudinal monitoring of the change of the CTC status. For example, for the group of patients when they have a high level of CTC at the baseline and between the pre-cycle-free time point when they receive the palliative chemotherapy, they tend to have a poorer prognosis. Similarly, for the group of patients receive curative treatment, those patients that remain low level of CTC with a favorable change between the pre-op and also the 3 months post-op time point, they also have a better, longer progression-free and overall survival. To summarize our CTC findings, the CTC clusters and the risk stratification based on the change of the CTC counts and the mutational burden provides prognostic information for this advanced ESCC patient. Longitudinal liquid biopsy serial monitoring also provide complementary information for prediction of the and prognosis of the CT response in the palliative group. Here, this is an example in this patient to illustrate how the serial CTC analysis can be used along his course of treatment. This patient received a chemoradiation therapy and then followed with a surgical resection. Unfortunately, at about 1 year post-op, he developed this disease progression, and then he switched to receive chemotherapy. And again, at about 5 months later, disease relapse was detected, and then he switched to the next regimen. When you look at these 5 different mutations, at the time of surgery, different profiles was detected between the resected esophageal tissue and lymph node tissues. And then when we look at the CT, along his whole course of disease, we collect the blood sample for CTC analysis. We found that both tissue and lymph node mutations can be tracked in the CTC, and also the CTC heterogeneity increased along the time course of his treatment. As a proof of concept experiment, we want to understand how the shedding of metastatic ESCC into blood. We want to understand the key signaling pathway involved in this CTC ESCC metastatic cascades by utilizing a patient animal model inoculated with ESCC patient-derived organoid xenograft. Our data also show that the genes involved in the EMT and also cancer stemness are regulated in the CTC isolated from ESCC patients. In addition to the liquid biopsy analysis, in addition to CTC, we also look at the circulating tumor DNA NGS profiling. This heat map summarized the top 25 frequently mutated genes in the circulating tumor DNA in 123 patients. Each row represents a gene, and here is the frequency of genetic alterations detected, and each column represents a patient, and the total number of mutations detected in each patient appear here as a bar chart. The most frequently mutated gene detected was TP53, 63%, followed by NFE2L2, 15%, and the PIK3CA mutations in 11% of the patients. We have validated the circulating tumor DNA mutations in the matched tumor tissues and lymph node tissues. About 55% of the circulating tumor DNA mutations have been found in the matched tumors. the circulating tumor DNA can capture both common and unique mutations present in the primary and also the lymph node tissues. The baseline circulating tumor DNA mutations are independent prognostic indicators in the palliative group of patients. In this group of patients, the presence of NFE2L2 mutation at the baseline and also the presence of with more than 2 genetic alterations at baseline are independent prognostic. For the group of patients receive curative treatment, we also detected the presence of post-neoadjuvant alterations and also with more than 1 genetic alteration in the post-op 6-month time point are independent prognostic indicators of poor prognosis. This slide illustrates an example of a patient when he received this neoadjuvant CT-RT treatment followed by surgery. The rise of this minor mutant allele frequency of 2 genetic alterations, namely NFE2L2 and TP53, had a 6-month lead time much earlier compared to the relapse detected by conventional imaging. When we compare the relapse time detected by the radiographic imaging with that of circulating tumor DNA, we detected 211 days average lead time with the cell-free DNA indicator in the curative group, and that for the palliative group is about 50 days. The circulating tumor DNA level and mutations are prognostic in both early and the late stage ESCC, and longitudinal change in the mutations precede the conventional imaging in detecting the tumor relapse. The longitudinal circulating tumor DNA real-time monitoring in ESCC may be useful to track the minimal residual disease and to identify patients with high risk for tumor progression much earlier than the conventional biomarkers. So to address these key questions, we utilize the patient-derived organoids. Compared to the cell lines, the organoids can better reflect the ESCC characteristic from a patient. Therefore, we obtain the receptor tissue and biopsy to establish a biobank of esophageal patient-derived organoids, including the esophageal squamous cell carcinoma organoids, esophageal adenocarcinoma organoid, and normal organoids. This ESCC, EAC, and normal organoids show a distinctive molecular features from each other and also resemble earlier NGS findings. We also, in this established esophageal organoids, we also utilize well-established cell proliferating markers and squamous cell markers to demonstrate that these are highly proliferating esophageal squamous cell carcinomas. NGS transcriptional profiling also showed that these patient-derived organoid cultures are more resemble the patient normal and esophagus tissues compared to the cell lines in terms of global gene expression. The most experiments are very important for cancer biology studies, so we inoculate this organoid culture into immunodeficient mice to establish the patient-derived xenograft animal platform. Similar to other patient-derived organoid, we can see that this ESCC organoid xenograft are also slow proliferating compared to the traditional cell line xenograft, allowing more time for their interaction with the host with the tumor microenvironment. In ESCC, there is no preclinical drug testing platform. Our recently established PDO or PDOX can serve as a great platform to explore many novel options of anti-cancer drugs and hopefully to identify potential anti-ESCC treatment options. As an example, we have performed pilot studies with a drug that depletes the immune cells. Utilizing this novel ESCC PDOX model, you can see that the depletion of the tumor-associated macrophage, which is an immune cell that can help cancer cells to grow and proliferate, the treatment group might show a significant reduction of the tumor size. The ESCC organoids can also serve as a better model compared to the cell lines for basic cancer biology research for characterization of the for molecular and functional characterization of key genes involved in ESCC tumorigenesis. As an example, we deplete MP63 in this ESCC organoids and demonstrated its oncogenic role by regulating the type 1 interferon via the virus mimicry evasion. To summarize our project's translational impacts, the first one, the integrative multi-omic analysis of the primary tumor and metastatic lymph node identified the importance of genomic instability in ESCC as potential prognostic biomarkers. The intratumoral heterogeneity was discovered in ESCC, while intratumor differences between the ESCC and the hypopharyngeal dual cancers support the multicentric independent clonal evolution and the importance of alcohol in its development. Single-cell RNA-seq also elucidate the various stromal subtypes and epithelial subtypes in the ESCC ecosystem and identify potential prognostic cancer cell transcriptome signatures. The comprehensive genomic profiling of good and poor responder to CRT treatment identify predictive biomarker associated with treatment response. We also identified the potential biomarker to guide treatment decision using serial blood testing by circulating tumor DNA and CTC analysis. And establishment of organoids and patient-derived xenograft for evaluation of useful drugs and development of animal models. Finally, we would like to thank the Research Grants Council for financial support. Our project is a team effort involving international advisory board and also multi-institutional collaborators from overseas, including Singapore and Australia. We would also like to thank the Shanghai collaborators for providing us the dual cancer specimens. And we also like to thank our Hong Kong U team member, including many clinicians from the clinical team and also basic scientists from the research team. That's the end of our presentation.
Okay, thank you, Professor Long and team. So now is Q&A section. So if you have any questions for them, so please raise your hand and let us know. So any questions at the back? Yes.
Thank you so much for your very nice talk. And then I have one question on the genomic analysis data. So did you have any chance to look into the non-human reads in the genomic data? And then I'm wondering if those reads can map to microbial genomes. So there are a few references out reporting microbial reads can identify it in the human blood samples. So I'm not sure if you have a chance to do so. And probably they can develop as prognostic marker as well, but I don't know. But just a very interesting question.
Okay, you want to look at the microbial genetic alteration, the presence of microbial in the blood DNA. Is that what you're asking?
Yeah, yes, that's my...
I didn't heard of that, but I think it's technically it is possible. You just need to isolate the plasma DNA and then develop a capture kit that can capture the sequences of your microbial. Then you can see, are they pleasant? But for myself, I haven't think of the microbial genome.
Oh, I mean,
but you can just need to design a capture kit to target capture of the microbial genome.
I see. So, I mean, for the existing data, did you see like a certain proportion of non-human reads in your data?
Are you talking about the... I didn't detect, for example, the EBV virus or other human papillomavirus. We didn't look at that. Because the role of human papillomavirus in ESCC is not so
Yeah, the imitator HPV in esophageal cancer is really not so strong, and for most of our patients, it's probably not relevant.
Oh,
Unlike
great, thank you.
cancers like EBV and PC.
Professor Loh.
Actually, just one comment on that. We have looked at microbial genomes in plasma, and they are there. They actually can be used as a marker for sepsis. Yeah, thank you.
Okay, any other questions for Professor Loh and team?
Just want to ask some questions to stimulate other people's thinking. When you say alcohol has a genetic link, yeah, to whatever cancer you're looking at, I thought it's just an association. Where's the genetic link?
We also, actually, I didn't present it here. We also look at the germline mutation of alcohol dehydrogenase. There is a functional slip that are present more frequently in the dual cancer patient compared to the primary ESCC patients. That is one of the genetic link. And we, of course, we need to do more studies to understand the underlying mechanisms.
But it's not a mechanistic thing, right? Alcohol dehydrogenase, what does it do genetically?
Yeah, I suppose, well, clinically, it's very well known, the aldehyde dehydrogenase 2 mutation is one of the strongest linked to esophageal cancer. We don't know the actual mechanistic link. The mutation, the highest incidence actually in Taiwan, among all Asian countries. Roughly about a third of Asians have this mutation, and Taiwan, for some reason, have a very, very high mutation rate.
So it's just an association.
It's
Just
an
like now saying if you have a COVID injection, now the chance of dying is very high. Because a lot of people have COVID injection.
Okay, any other questions from the audience? So maybe I can just have a very quick question. So you have presented a lot of different aspects to tackle this cancer. So which direction you think it will be helpful to boost or to drive the precision medicine against this disease?
I think identifying target drugs is still the most important issue. I mean, we have those data showing monitoring of response. But often the question is, okay, so what? If you have a poor prognostic marker, if you can detect the disease recurrence earlier with the lead time, what can you do? The problem is that currently the drugs are still pretty bad. I guess we can start the treatment earlier. Latest kit on the block is immunotherapy, but still under investigation. There are some new targets on the block. Maybe Professor Kwong can comment. Dora, would you like to have some comments?
Thank you. So as Dr. Koh have just shown, we actually identified the top four of the top four most common mutation looked in ESCC. The most common is actually the P53, which is at present is a very common mutation for many types of cancer, but is unfortunately still not druggable at the present. But the next two, the NFE2L2 is also quite common in ESCC and is also common in lung cancer as well. So people are trying to target this gene mutation. PIK3CA also very common in many types of cancer, and now we actually have specific target drugs against PIK3CA, which is actually in clinical use in breast cancer already. So there are hope that if we identify those target mutations in the patients, then we can try, see whether this target therapy can be useful.
So thank you. Any other questions from the audience? Okay, if not, then we thank Professor Loh's team for this presentation. So this is actually the end of the morning section. So just some